network of people living with HIV in Mozambique. And then Dr. Richard, who is the head of care and support, and also the DSD focal person, Minister of Health, Democratic Republic of Congo. And then finally, from Madame Clarice Mudiambo, who is the supervisor for the national supervisor for the PODIs and Democratic Republic of Congo. So we're going to start with Mozambique, and our first presenter will be Dr. Alenu Kuto. Dr. Kuto, please go ahead and unmute yourself. Please, you have 7 minutes for this presentation. Thank you.
Thank you very much for this opportunity. I think we can move the slides. In terms of results of COVID-19, till June 1st, we can see that almost 11 people were tested for COVID-19 through all country in the 11 province. 10,000 were tested negative and 254 people were tested negative. Till yesterday, 96 people were recovered, 155 still active to COVID-19, and we already have 2 deaths in country. In terms of the measures, since we are having lockdown since by the end of partial lockdown, not total lockdown, but partial, by the end of March, is the same time that we issued our policy, how we're going to move in terms of still giving continuing of activities in terms of HIV. At this level, we're calling that we are at level 3 of our partial lockdown. What we have is the restriction in terms of agglomeration has to be less than 10 people. We have restriction in terms of a commercial sector. We have the compulsory use of masks in public places. We have obligatory severe regulation of employees in presential regime. So we are not going to work everyone, but we have to work in rotativity. So some people go 15 days work, then rest 15 days. And we have provision of all events in terms of sports, cults, and all activities that has been public has been prohibited to continue. Next. Can we go to the next slide, please? In terms of guidelines, what we changed, we had 4 main pillars, and the first one was in terms of infection control and recipient of care education. What we did was, in terms of infection control, was we suspended the testing at community level. We suspended home visits by peer educators and other HIV activists. That was suspended. All support group meetings were suspended except for community adherence group. In terms of community adherence group, the recipient of care were educated to keep social distance, and the group meetings were suspended. It can only happen just to deliver of the drugs. The lay personnel now was dedicated to do HIV care and treatment activities inside of a health facility, organizing the queues, doing the calls, all this, and doing all patient flows that has to be adapted so we can provide some COVID-19 prevention, education, and screening within health facilities. The other pillar was in terms of reducing the frequency of the recipient cares, the visits that they have to pay to the health facilities. And these terms that we have to do, we have to really change our guidelines in terms of providing 3 months drug distribution. What we did was introducing 3 months drug distribution, and fast track had to be scaled up through all countries, not just in some health facilities. So this is one of the advantages of this COVID-19, that was really scaled up our 3 months drug distribution. We had to do all 3 months drug distribution for patients older than 2 years. The 3 months drug distribution is not only for ARVs, but also for isoniazid, cotrimoxazole, and other chronic disease like hypertension and diabetes. The community adherence support groups eligibility criteria was extended, so we had to really expand it to other ages. And also the viral load sample collection and results delivered were aligned with the clinical consultation and drug pickup. So this has to be it had to be aligned. So so we cannot have so many visits of recipient of care to the health facility. Next slide. Next slide. In terms, within health facility, what we did is reducing waiting times in the health facility, not just the visits, but within health facility, we had to really reduce the time of waiting time inside the health facility. So what we did with some patients that goes to health facility, they go directly to the designated consultation room. So they go one consultation, they be assisted, and we had a one-stop shop where we can deliver drugs inside of that room. The psychosocial support has to be done in the same clinical consultation also. The health facility provide drugs we have to provide drugs in the health facility, in the consultation room. So we had to really adapt the one-stop shop that was not done before, because before we had consultation, one room consultation for psychosocial support, then go to the doctor, have the consultation, then go to the pharmacy to pick up the drug. Now we concentrated everything in one room so we can deliver the psychosocial support, the consultation, the clinical consultation, and also the drugs in one room. For those patients that are not coming to the consultation, we really have to scale up the fast track, and 3 months drugs, 3 months the drug deliver was really the 3 months drug deliver have a clinical consultation every 6 months. You know, we expanded the 3 months drug deliver, but the consultation has been expanded for every 6 months to come to the health facility. So at the month 3 and 9, we go directly to the pharmacy to pick up our drugs. In terms of innovation and best practice, one of the things that we really have to adapt for those ones who are not coming to the health facilities, we are calling them to do the psychosocial support that has to be done by a phone call. We had to adapt a SOP so we can orientate that person. They have to call the patients. Those ones who have phones. For those ones we don't have the phones, we are using our radios so we can deliver message that they have to come to the health facility to pick their drugs. They can take 3 months drugs. 3 months drugs for stocks, and also is a moment that we do our psychosocial support. The viral results also have been delivered by phone call, and then we are including enhanced adherence counseling through phones. The health facility were instructed to and how to fill the patient's file in order to be possible to distinguish between patients who were included on DSDs because of COVID-19 and those who were coming for formal criteria. We're also doing the monthly Zoom calls with the provincial HIV teams to identify the problems on the implementation of this circular and share best practice that happen within the province, so we can overcome some problems that we can find on the field. Also, we are really looking at our data in a monthly basis to identify gaps and realign the strategies. We are now seeing that we have some drops. We are not seeing that we increase, the people are not coming to the health facilities, and I'll show this data. So that means that we have to really realign our strategy, how to can reach those people. And we can see that the 3 months drug distribution was something that really came up, that was really reinforced, and we can see some increase of number of people now that are being delivered to 3 months drug distribution. Next. Next slide, please. Can we change the slides to the next one? In terms of patient flow, we have to really adapt the patient flow. At reception, we had to give the patient the COVID-19 prevention information. We wait and we take the height measure at this. So we have the distribution of the Mastercards to the consultation rooms, and we guide our recipient of care in which consultation room they will be attended. In the waiting room, we see the COVID-19 in the waiting room, we are doing, if we are giving also, apart from the information, we are screening the patients for COVID-19. Then the person goes to the clinical consultation room. There we have or a doctor or lay counselor that can give us support on psychosocial support. We do the screening of nutritional screening, TB, and other opportunistic infection screening. We have the measure of hypertension. We can screen also for not screening, but the screening of diabetes and hypertension. And we give there at this room dispensing of the prophylaxis and also the ARVs. And give them the lab sample requisition. Some of them can go directly to the lab. They will be prioritized to take the maintain the laboratory routine laboratory tests that are for HIV. If they have co-infections, if they have some other comorbidity like diabetes and hypertension, we also take the lab test being performed. The others, apart from lab, also go to the pharmacy for those ones who cannot deliver in the room. But most of what is happening now, most of our facilities that they are delivering in the room. But for those ones that were not possible to go to deliver in the room, some of them go to the pharmacy, so we can have the drug dispensing and have some information about the drug dispensing. And some of them then can go to the community. For those that are from our community adherence support groups, they take the drugs and take all those drugs to distribute at community. They go to the community to distribute to the other members of the group. But we also did a lot of information in terms of COVID-19, in terms of prevention. We are still delivering PrEP. For those ones who are doing PrEP, we are not just doing 1 month dispensing. We are giving 3 months dispensing. So we are here. These posters are showing that we can do. We are allowed to give. So the recipient of care can ask for 3 months drug dispensing if he wants to when it comes to PrEP. Also, we are explaining that the 3 months drug dispensing is in the health facility for everyone that has criteria. So we cut down our criteria. We used to be 6 months. Then if he's eligible, we give 3 months drug dispensing. But we move from 6 months to 3 months. After 3 months, if you're already on treatment for 3 months, you are already eligible to 3 months drug dispensing. And for our pregnant women, what we did is that every 3 months they can have 3 months drug dispensing also for those ones who are pregnant. For those lactant women after delivery, they go to the health facility every month during 3 months. After that, we can assist her every 3 months also. Can come to the health facility every 3 months. And this yellow poster is just if you want some information in terms of COVID-19. Next slide. Next slide. In terms of what we are seeing in terms of monthly consultations, we can see in the first 3 months we had increased. Then now we are seeing some drops in March, in April. We are seeing some drops in terms of new text new also. We saw some drops from March to April. In terms of text curve active people on treatment, we didn't see so much change, but we didn't see the growth that we used to see, like we said, from January to February, and February to March. From March to April, we didn't have so much increase. Maybe it's because we didn't initiate so many patients from last 2 months. And in terms of viral load sample collected and having results, also we are seeing some drops from March, mainly from March to April. Next. In terms of monthly defaulters, we saw that some growth from March to April. We had the increase from 8% to 10%, but at the same time, we saw that the 3 months drug distribution increased from 34% to 45%. And next. And what are our priority questions in terms of this COVID-19? We really have to develop and adapt more DSDs to ensure better coverage. We have to really improve our clinical follow-up for recipients of care, which are enrolled on DSD after the end of pandemic. And our current discussion that we have now is the return of home visits and community HIV counseling testing, if they have to be back or not. And thank you very much. This is my last slide.
Thank you very much, Dr. Kuto, for that nice presentation. May I now invite our next presenter, Dr. Mahudu Bonu from EGPAF Mozambique, to share impact and mitigation of COVID-19 on HIV services in the Gaza and in Hambani province in Mozambique with us. Dr. Bono, please take over.
Thank you.
Oh, 1 minute,
Thank
please.
you
Just a quick reminder to all participants, please, if you have any questions, type them in the Q&A box, select all panelists and put in your question there. And I encourage our panelists to please try your best to answer the questions in real time. Thank you. Dr. Bono, please take over.
Okay, thank you very much. I'm pleased to present this impact and mitigation of COVID-19 on HIV services in Gaza and Nyamban province as an experience of EGPAF in Mozambique. Slide please. To assure the continuity of the services, some measure has been taken at inside our organization. All our staff at provincial and national level start working from home, and all our staff based at the district and the site level, they continue as before, but with PPE provided. For most of the training, there has been canceled with those presential, and the only few ones that we through Zoom. Following all the changes on the national guideline that Dr. Aleni has presented 2 minutes ago, all our activities at community level has been suspended. No loss to follow-up tracing, no testing at community level, no visit, preventive visit. The patient flow inside the site has been redesigned to allow all patients to be screened for COVID-19 and also to be sure that they follow from basic prevention measure inside the health facility, such as to clean their hands, to wear masks, and also to respect the social distancing at the waiting area. Patient and community sensitization has been done to inform them on the fact that only the patient with chronic disease and patient presenting a certain emergency situation can come, our priority to come to health facility. As it has been presented, multi-month dispensing has been allowed to more patients, including the pediatric one. So some demand creation has been done. Also for antenatal visits, the changes that has been presented are really explained to the health providers and also for our staff. The changes at the child at risk consultation and postpartum consultation also has been taken into account. All our support to our team at provincial and district level has been suspended, talking about physical visits, and also our expansion that we were planning for IDAT has been suspended as well. Slide, please. This slide is to present what has been our response. So as you can see in the, on top, as community-based testing has been suspended, so we focus our testing at site level and also on linkage, demand creation for multi-month dispensing and also for GAC. IPT as a criteria has been flexibilized to include now patients that who are also on multi-month dispensing. That has been done. The counseling, all the psychosocial support were done through telecounseling, and also the patient tracing through calls and not anymore through visits. As I said before, all the training, all the meeting that we used to do has switched to a telecontact. Through WhatsApp, we use this to send quickly the guidelines, the changes to, or some of the explanation to the health providers. We also help to reproduce the changes that has been made on the clinical guideline, and also specific guidelines that has been produced on the follow-up of patients or suspected patients for COVID at a facility level. And for sure, some PPE for our staff and also for some of the staff at the system. Slide, please. This graph, it is to present the trend of the impact that we have on the patients who are missing the drug pickup. As we can see, from February to April, we are seeing an increase of the percentage of patients who are missing the drug pickup in Gaza and in Nyambane. In April, we have now 5%, while in Nyambane, we are now at 6%. For the graph in the middle, this is presenting the response to this missing appointment that we have. Those are the preventive calls. So for eligible patients, those eligible patients are the patients who had the appointment the following week and who has provided a phone contact. So due to some challenges, there is a variation on the coverage of those eligible patients. The last graph that in this slide is presenting our trend in the enrollment of patients on multi-month dispensing, talking about the 3 multi-month dispensing in Gaza and Nyambane. We can see that from March to May, the number of patients on this DSD has doubled in both of the provinces. Slide, please. This slide is presenting the change that has been made for the monitoring of the program. We received some clear guidance from CDC extending the deadline to data collection, and also to give priority to data which can be collected through which can be collected electronically, and to drop all data with manual sources. Also, some adaptation has been made at site level, especially talking about the data operators who start working on a switch mode, and also respecting a physical distancing, wearing PPE, everything. The supervision done to them is done remotely, and also all contact with upper level is done through correspondence, electronic correspondence. As you can see, the last bullet is about a set of indicators that we agree on internally to be tracking the impact of COVID-19. We have the antenatal care, the yearly infant diagnosis, the HTC, the new cases of TB, yearly retention trends, the patient currently on ALT trend, the viral load trend, and also the enrollment on multi-month dispensing trends. I think this is what I have to present. Thank you for your attention.
Thank you very much, Dr. Bono. That was a very interesting presentation. Please, if you just joined us, we are having simultaneous interpretations in French and Portuguese. So please choose go to the globe at the bottom of your screen and select your language of choice. Our last presentation from Mozambique will be from the recipient of care community, and Mr. Lorenzo Sumbani will lead us in that. Lorenzo, please take over.
Boa tarde a todos. Farei a minha apresentação em português. Hello? Hello?
We can hear you, please go ahead.
Ok. Bom, primeiro agradecer a apresentação dos colegas de Moçambique, a doutora Liens e o doutor Bonon, né? Fizeram que me antecederam. Mas eu tenho em forma de, nem a apresentação, em forma de comentário. Primeiro, de facto, esta questão do Covid em Moçambique pegou muitos pacientes em Tarve de surpresa. Tenho como comentários, por exemplo, tiveram grandes dificuldades, primeiro porque as abordagens tiveram que ser alteradas. Falo primeiro da questão da mudança das unidades sanitárias. Há unidades sanitárias em que os pacientes faziam seu TARV, mas que no âmbito do Covid houve a necessidade de se mudar esses pacientes para as outras unidades sanitárias. E isto criou um pequeno problema no começo do processo. Ok? Criou um pequeno problema no começo do processo. Já sabemos que os pacientes já estavam habituados numa unidade sanitária por vários fatores. Primeiro, por questões de confidencialidade, é perto das suas zonas de residência, e vários fatores influenciam. Agora, com esta mudança de unidades sanitárias, houve este pequeno problema, algum problema também da própria retenção dos pacientes nas unidades sanitárias. É uma das pequenas reclamações, porque a informação, a partir das próprias unidades sanitárias, não era clara daquilo que devia ser o procedimento destes pacientes que estão em tratamento. Agora, o outro problema, não é problema, agora, nem tudo esteve errado, porque o próprio Ministério acabou, em função do tempo, melhorando a sua abordagem. Porque tivemos também que o Ministério fez uma coisa interessante, que foi readaptar-se quando elaborou a circular, né, no âmbito da Covid, que pronto, já acabou já fazendo esta revitalização dos GACs, porque era um dos modelos diferenciados que estavam a ser esquecidos em Moçambique. Mas com esta nova abordagem, nessa nova circular, a grande prioridade para os GACs, dispensa trimestral dos ARVs, e também esta questão dos pacientes terem que ir à unidade da marcação de consulta, de unidades sanitárias, em 6 meses, sempre que for necessário. Então, estes pacientes não estão muito expostos ao Covid nas unidades sanitárias. Agora, há uma outra necessidade também que nós olhamos que deve-se reforçar mais, que também acredito que o Ministério esteja a fazer, que é da informação para estes pacientes que estão em TARV nas unidades sanitárias sobre a prevenção do próprio Covid, porque sabemos que das informações que nós temos é que esses pacientes HIV positivos e outros com outras doenças associadas são muito propensos à Covid. Então, cria esta questão de pânico em alguns pacientes que até acabam tendo este medo de se dirigir às unidades sanitárias. Agora, há esta necessidade de se melhorar esta informação para com os pacientes que estão em TARV. Agora, a outra questão que talvez seria interessante também abordar é que, bom, o Ministério está de facto a fazer o seu trabalho. Acreditamos que está a ter as suas dificuldades, porque são coisas novas que foram nos encontrando como pacientes em Moçambique. Agora, o que eu apelaria, na verdade, é a questão da informação a nível de base, porque a nível de políticas não há nenhum problema, porque acreditamos que as políticas estão, se existe também uma circular que prioriza os modelos diferenciados mais comunitários, isso demonstra que há um interesse a nível político do próprio Ministério. Mas, a nível das unidades sanitárias, há esta dificuldade de perceberem ou de interpretarem estas novas abordagens para com os pacientes. Então, há esta necessidade de um trabalho de base com os provedores de serviços a nível da própria unidade sanitária, para que a informação chegue de forma atempada e correta para os pacientes. Porque muitos pacientes agora têm a ideia de, pronto, neste momento do Covid, não se deve ir à unidade sanitária. Há alguns até numa situação de precisarem de fazer as suas consultas, mas sentem este medo de se dirigir à unidade sanitária. Mas acreditamos que o trabalho está sendo feito, vai sendo melhorado. A recomendação acho que ficou. Nós também, como sociedade civil, temos nosso papel a fazer, não é? Na questão de provisão de informação correta e consistente para os pacientes que estão em TARO. Inicialmente, acho que seriam estes meus primeiros comentários que faria daquilo que foram as apresentações e daquilo que é a realidade para os pacientes que estão em TARO em Moçambique. Muito obrigado.
Thank you very much, Lorenzo, for the perspectives from the experience of care community in Mozambique. I'm going to transition to the Democratic Republic of Congo, and I'm going to hand over to my co-moderator, Dr. Great Vanderbilt, to take over from here. Thank you.
Ok, bon après-midi encore à tout le monde. Alors, nous allons continuer avec
nous pouvons commencer.
De Dr Richard Ingwe, qui est le point focal pour les soins différenciés en RDC et chargé de soins et traitements au niveau du PNLS. Alors, Dr Richard, vous pouvez activer votre micro et commencer la présentation.
Merci beaucoup. Je vais devoir commencer, vous faire un topo sur ce qu'on a apporté comme amélioration dans l'offre de services différenciés au pays. Slide. Diapo. Voilà, là, nous sommes en train de vous présenter notre situation de COVID-19. Depuis le 10 mars, il a été proclamé le premier cas jusqu'à aujourd'hui, le 29 mai 2019. On est en train de friser 3000 cas dans 7 provinces sur les 26 que compte notre pays. Et donc, 90% se retrouve concentré à Kinshasa, qui est notre capitale. Et la deuxième province qui est concernée, c'est Congo central, avec 189. Vous allez comprendre que Congo central et Kinshasa, ils sont rapprochés. Et nous avons enregistré jusque-là 69 décès. Donc, les provinces dans la carte, vous allez voir, ils sont dispatchés comme vous les voyez. Slide. Diapo, voilà. Dans tout ce temps, quand on offre les soins différenciés chez nous, il y a un certain nombre de critères d'éligibilité que nous avons pensé, avec le contexte de COVID-19, pas opportun de continuer, notamment les différents critères qui sont devant vous là. Être sous ARV depuis une année, avoir une charge virale inférieure à 1000, être adhérent au traitement, ne pas avoir une union dans les 3 derniers mois, pas être enceinte, être au moins âgé de 15 ans et puis absence des effets indésirables, mais aussi un bon état nutritionnel. Slide. Diapo. Voilà, pour ce qui concerne les approches groupes, au pays, nous opérationnalisons 2 approches. C'est le club d'observance et le groupe communautaire TAR, qui est connu sous le nom de CAG. Alors, ces approches restent encore à questionner au niveau du pays, mais pour des provinces concernées par la COVID-19 et plus précisément dans les districts sanitaires qui sont concernés par la COVID-19, nous pensons que ces approches vont évoluer timidement. Et dans les provinces qui ne sont pas encore touchées par la COVID-19, ces provinces, ils peuvent continuer à offrir les services avec les approches groupes, mais en respectant les mesures de distanciation sociale, en respectant toutes les mesures barrières par rapport à la COVID-19. Slide. Alors, pour les fast track, c'est vraiment l'approche que nous avons intensifiée au pays et que nous voulons pérenne. Donc ici, nous avons même élargi la cible. Régulièrement, on avait un renouvellement de 3 mois pour les patients stables. Maintenant, pour tous les patients qui étaient stables et qui étaient déjà sous les modèles différenciés, il y a un renouvellement maintenant qui est recommandé de 6 mois, à grande modification. Et pour tous les patients qui sont sous ARV depuis plus de 3 mois, ils auront un renouvellement de 3 mois avec un suivi très rapproché téléphonique avec des SMS remind. Pour nous, les traitements prophylactiques à la tuberculose, mais aussi le cotrimoxazole, nous pensons que les patients peuvent commencer à renouveler chaque trimestriellement. La réflexion va dans le sens, est-ce qu'il serait opportun d'administrer complètement toute la cure de la prophylaxie à la tuberculose Ce sont des questions qui sont encore en discussion pour pouvoir adapter notre guide. Slide. Pour ce faire, donc, il a été décidé de minimiser de manière considérable les contacts entre les prestataires et les bénéficiaires de soins. Ceci a obligé à ce que les prestataires des sites fassent un travail de fond et d'étiquetement, notamment celui de lister tous les patients qui ont des numéros téléphoniques, qui ont des téléphones, et tous ceux qui n'en ont pas. Et pour les patients qui ont des numéros téléphoniques, ils organisent cette fois-là des visites, des horaires différenciés sous appel téléphonique et prendre le rendez-vous au téléphone et fixer même l'heure de visite au niveau de la formation sanitaire. Pour ceux qui n'ont pas de téléphone, un agenda a été tracé pour commencer à servir les différents patients à domicile. Et un briefing sur les mesures de prévention, mesures barrières pour les pairs qui devraient aller approvisionner les malades concernés qui n'ont pas de téléphone. Slide. Diapo. L'autre changement majeur, c'est les critères d'éligibilité pour aller dans les soins différenciés qui ont drastiquement changé. Vous allez constater que ça concerne maintenant actuellement tous les patients et ceux qui ont moins de 12 mois sous traitement et ceux qui ont plus de 12 mois sous traitement. Ça concerne tous les enfants, quel que soit l'âge, donc ils ont un renouvellement différencié. Ça concerne aussi maintenant les femmes enceintes et allaitantes, mais aussi les patients tuberculeux. Ces patients, nous essayons aussi, à tous ces patients, nous sensibilisons sur les signes d'alerte, notamment la fréquence respiratoire, la toux, la fièvre, pour pouvoir permettre à ce qu'ils soient en alerte et aller consulter rapidement les sites de soins. Slide. Diapo. Un autre changement majeur, c'est pour tous les patients qui auront moins de 6 mois, c'est vrai que le renouvellement, il est espacé, mais il est installé un système de suivi rapproché, par exemple, appel téléphonique une fois le mois, avec suivi des effets indésirables, évaluer l'adhérence au traitement, mais aussi pour tous les patients qui sont encore nouvellement reçus, faire un check-up de la COVID-19, mais aussi la tuberculose. Pour les tuberculés, comme vous le savez, nous avons 15 jours avant de commencer les ARV si c'est un tuberculé diagnostiqué VIH. Alors, les tuberculés qui sont diagnostiqués VIH, pendant qu'ils ont renouvelé leur traitement anti-T, on leur donne aussi la boîte de traitement, mais en mentionnant la date qui va commencer le traitement. Et ce jour-là, un appel va le suivre pour s'assurer qu'il a commencé le traitement avec les ARV. Slide. Les questions prioritaires, c'est que toutes ces interventions qu'on vient de citer, c'est encore opérationnalisé dans peu de provinces, surtout les provinces concernées par la COVID-19, notamment Kinshasa et Haut-Katanga, Walaba aussi. Nous sommes en train de nous dire comment passer à échelle dans les 26 provinces pour pouvoir améliorer la prévention contre la COVID-19. L'autre question prioritaire, c'est vraiment la logistique pour des zones de santé à distance. Il y a des districts sanitaires qui se retrouvent très éloignés des CDR où on devrait renouveler le traitement. Comment faire pour pouvoir les atteindre avec les médicaments là où ils sont éloignés? L'autre question prioritaire, c'est en fait, nous sommes en pleine transition vers TLD et que cette transition, nous pensons que les approvisionnements qui sont disponibles sont encore incomplets et que comment on va assurer la disponibilité des intrants qu'on commence à renouveler à 6 mois, à 3 mois pour pouvoir permettre la continuité des soins. Alors, le dernier élément qui nous préoccupe, c'est souvent le traitement pédiatrique. Tout ce temps, il n'était pas encore suffisamment opté à le choix des soins différenciés chez les enfants. Mais maintenant qu'on commence à opérationnaliser les soins différenciés chez les enfants, que faire pour assurer la continuité et la disponibilité d'ARV et aussi l'approvisionnement des enfants en grande quantité comme on le fait, avec des médicaments qu'il y a disponibles. Toutes ces approches ont des outils de collecte qui sont développés encore par-ci, par-là. On essaie de collecter les informations rapidement pour pouvoir suivre si est-ce que ça réussit, est-ce qu'il y a des patients qui ratent leur traitement, est-ce que tout marche. Et donc, ces outils-là n'ont pas été présentés dans cette présentation, en attendant que nous puissions voir quelle est son efficacité pour pouvoir passer à échelle et décider à élaborer complètement des outils de manière élaborée. Pour terminer, le slide. Pour terminer, l'image qui est derrière là, c'est une image qui montre des Zoom réunions qui s'organisent entre les acteurs de lutte contre le VIH. Ça, c'est un suivi vraiment au niveau des sites, où on appelle les structures sanitaires pour pouvoir suivre comment ils opérationnalisent les différentes stratégies que nous venons de vous expliquer, les grandes modifications qui se sont installées au niveau de pays. Je vous remercie.
Merci, Dr. Richard, pour cette présentation intéressante. Nous allons poursuivre avec la dernière présentation de ce webinaire par Madame Clarisse, qui est membre du réseau national des personnes vivant avec le VIH en République démocratique du Congo. Elle va nous partager l'expérience des PODI pendant la période de COVID-19. Madame Clarisse, vous pouvez commencer votre présentation. Merci.
Oui, merci. Je suis Clarisse Mawika, superviseur national des postes de distribution des ARV. Slide. Mon numéro de téléphone, les mails, c'est à côté. Je vais partager avec vous l'expérience des PODI pendant le COVID-19. En commençant par les PODI. Les PODI, c'est les postes de distribution des ARV pour les patients stables qui ont une charge virale inférieure à 1000 copies. Les fonctionnements, la fréquence est de 5 jours par semaine, mais suite au COVID-19, nous avons réduit ça à 3 jours. Les rendez-vous est de 3 mois et 6 mois pour les autres, ceux qui ont fait plus de 5 ans au PODI. Les PODI est adapté dans les sites urbains et dans la communauté. Les PODI doivent être placés dans la communauté, pas dans une structure, pas dans un hôpital, mais c'est dans la communauté. Qui travaille au PODI? Ce sont les patients experts, donc les pairs PVVIH. Que font les partenaires au PODI? Les partenaires nous apportent l'appui technique, matériel et financier. Slide. Slide. Comment se fait l'approvisionnement des patients en ARV au PODI? Il y a premièrement, on fait l'inventaire de la pharmacie des PODI, comme nous montrent les graphiques. Il y a l'inventaire qui se fait. Après, on valide les listes auprès des centres de santé parce que les patients ne sont pas les patients des PODI, mais ce sont les patients des centres de santé qu'on nous a référés au PODI. Il y a la zone de santé aussi qui valide. À la fin, ça nous retourne au PODI et nous faisons la commande vers la zone de santé. La commande, nous la faisons pour 3 mois avec un stock de sécurité. Pour les patients qui ne sont pas attendus, il y a les présumés perdus de vie, il y a les perdus de vie et il y a les autres patients qu'on nous envoie vers le site qui viennent pour récupérer les ARV, mais on les sert dans les stocks de sécurité. Comme nous montrent les graphiques, PODI est au centre, il y a les centres de santé, la zone de santé et les partenaires. Ce sont des acteurs très importants pour les PODI. Slide. Avec le COVID-19, nous ne pouvons pas rester à l'écart. Quand même, nous avons des patients. Le VIH avec le COVID, c'est difficile pour vivre avec tous les deux. C'est comme ça. On a quand même pris les mesures barrières. On applique les mesures barrières. Il y a mise en place des mesures de protection, système de triage. Nous avions diminué les rendez-vous des patients. Par jour, on recevait parfois dans des PODI qui ont des grosses cohortes, on recevait 40 à 50 patients, mais nous avons réduit ça à 15 patients par jour pour protéger aussi les prestataires et d'autres patients. Les dépistages qu'on faisait, au PODI, on ne fait pas les dépistages contre les COVID-19. La disposition des sièges, le respect des distanciations, port des masques comme nous démontrent les photos. Donc, tout ça, nous les appliquons au PODI. Pour le respect de la confinement, 3 jours de travail, nous avons réduit les jours de travail à 3 jours par semaine au lieu de 5 comme c'était avant. Il y a la distribution des ARV pour 3 et 6 mois, comme je l'avais dit bien avant, pour les autres. Modification apportée, l'équipe de prestataires a été scindée en 2 groupes à la mise en place du système de roulement. Donc, on fait le déroulement. Il y a les autres qui viennent les lundis, il y a lundi, mercredi, vendredi. Il y a les autres qui viennent mardi et jeudi pour qu'il n'y ait pas des absents au PODI. Slide. Impact du COVID-19 dans les PODI. Compte tenu des mesures que le gouvernement a mises en place, comment est-ce que nous avons fait pour les patients? Nous nous sommes organisés pour des patients qui ne viennent, qui ne sont pas venus au rendez-vous, donc les absents. On les appelle par les appels téléphoniques. Il y a livraison aussi à domicile. Si on connaît son adresse est vraiment bien confirmée que c'est son adresse, on y va vers chez eux et on les sert. Il y a aussi les confidents. Parce qu'au PODI, 80% des patients ont déjà partagé leur sérologie, soit avec une amie, soit avec un membre de la famille. Donc, nous exigeons à ce qu'il y ait les confidents. C'est comme ça, à partir de là, s'il n'est pas là ou bien il est empêché, il envoie son confident pour venir chercher ses ARV. Il y a aussi ceux qui sont en déplacement, envoient leurs confidents pour venir récupérer les ARV. Il y a un problème aussi. Nous faisons les CDV, mais actuellement, les CDV, nous avons diminué le dépistage VIH. Priorité aux cas spécifiques. Les sensibilisations, nous ne les faisons plus parce qu'on faisait des sensibilisations dans la communauté. Actuellement, on ne peut plus les faire suite au COVID-19. Les défis pour les autres défis. Au PODI, pas des outils de sensibilisation sur le COVID-19. Donc, jusque-là, nous ne sommes pas nous n'avons pas des outils pour sensibiliser, mais avec d'autres patients, les patients qui nous viennent au PODI, on essaie de sensibiliser avec les pays que nous avons. Donc, ceux que nous connaissons, nous les sensibilisons. Pour les patients, en tout cas, on ne nous envoie plus les patients. Les structures ne nous envoient plus les patients, donc il y a un problème. La charge virale aussi est indisponible. Donc, tout ça, c'est un problème. Donc, indisponibilité de la charge virale. Bon, je vous remercie.
Merci, Madame Clarisse, pour cette présentation. Nous sommes maintenant venus à la fin de la présentation et passons à la session de questions-réponses. Alors, je vais passer la parole à Peter pour modérer cette partie de ce webinaire. So, Peter, I'm assigning this back to you for the questions.
Thank you very much, Dr. Great. And thank you to all the presenters. Very interesting presentations we've had today. I think we still have some time for live Q&A. So I would like to ask a few questions that have not yet been answered. So to Dr. Mahundu, there's a question about monitoring the indicators to track the impact of COVID-19 and whether you are using new M&E tools or you are using pre-existing ones. I'm sure we can ask the same question to our DRC colleagues.
Yeah, go ahead.
Please.
Thank you. Thank you very much for the question. I answered already, but I can repeat it. What I said is we are not going to use new tools to track the impact because this will require a lot of exercise even to go to the field as it will be primary data collection. What we are doing to use the same data tools that we have and then to be tracking the trend before COVID and then at the era of COVID, or to follow the trend since January until the moment. So this is a question related to the tools. There was a question also related to the self-testing. The guidance are not yet released at national level for the self-testing. They are still working on it in different technical working group. So once they will be, it will be released a clear guidance on self-testing, then we will think about the implementation. Thank you very much.
Thank you very much for the response. Richard, in DRC, how are you monitoring these policy changes and implementation in response to COVID? Are you using new M&E tools or pre-existing ones are being used?
Exactement, comme vous venez de le voir, il y a plusieurs approches qui sont en train d'utiliser plus l'ENTIC, donc nouvelles technologies de communication. Il est pour nous important et déjà c'est développé. Il y a un certain nombre d'outils de suivi qui ne sont pas vraiment volumineux, qui essaient un peu de rapporter les éléments essentiels qu'il faut capter pour voir les changements qui peuvent arriver et pour voir quel serait l'impact des différentes approches qu'on a mis en place pour pouvoir passer à l'échelle. Mais je ne pense pas que les indicateurs vont changer. Les indicateurs ils vont rester les mêmes indicateurs qu'avant la COVID-19. Ce qui va être à faire, c'est de comparer ces indicateurs-là avant la COVID et après la COVID-19. Merci.
Thank you very much. I was also wondering, in terms of compliance to these policy adaptations, how are we, in terms of supportive supervision, how is that going on? Are our supervisors able to go to sites, or is it being done remotely? How are we making sure that these policies are being complied to? Dr. Aleni, I don't know if you can respond to that.
I can respond to that. In terms of supervisions, we are not going to the field just now. We suspended, but we are doing remotely. We really have to rely on data that is being sent by them. So that's why I present that data. And from that data, we are discussing, is that what I said, with our supervisors in the province. But we are not going to the field at this moment. They're going to the field to see how is the implementation of the COVID circular is going on, because sometimes they find some difficulties. But I don't think that we are going regularly as much as used to be. We are reduced a lot going to the field at this time. So the monitoring has to be remotely.
Okay. Thank you very much.
For EGPAF team, this is the same. A physical supervision is not done, but on a weekly basis, we have a calls with a team to track all the implementation to see what are the challenges that they are facing and how we can overcome them on a remote way.
Great. So I'm wondering, just a quick question that will probably lead us into our next week's webinar, which is on supply chain. I'm wondering if you guys are experiencing or anticipating any supply issues during this period. Dr. Leni and Dr. Richard.
In terms of supply, can we?
Okay.
Dr. Leni, please go first.
I'll go first. Okay. In terms of supplies, what we did is that before that we issued the circular, we had to really guarantee ourselves that the drugs will be there. And what we said in our circular is that we have to really have close monitoring of the drugs. Where it is not possible to give 3 months drug distribution, please don't do it. You have to reassure that you have the drugs there in the health facility. If you don't have enough stocks to do that, don't take that step. But if you have, but at this moment we have no report of problems with the drugs, and the drugs are there, and people are really doing 3 months drug distribution. In terms of ARVs, well, that there's no reports that come to our knowledge that there's a problem with the report of the stockouts of the drugs, because we said in the circular, monitor weekly. We have to monitor if you have enough drugs. If you don't have it, please don't give 3 months drug distribution, because we don't have, we don't want just our people, other recipients of care come to the health facility, don't have drugs enough, because we already gave it to someone else. So from now on, and you saw it, the increase of number of people from 3 months drug distribution is there. Thank you.
Yes, thank you very much. Quickly, 30 seconds, Dr. Richard.
Oui, merci. Pour nous aussi, c'était la même chose. Avant de lancer les différentes approches, il y a eu des rencontres pour évaluer les situations, faire une évaluation, l'inventaire rapide des situations de stock au niveau du pays. Et donc, après, on s'est rendu compte qu'il y avait suffisamment de stock pour lancer le processus. Mais en long terme, il y a ce risque-là pour qu'il y ait de stock par-ci, par-là. Les intrants qu'on a parlé plus, c'est des intrants des approvisionnements des intrants des enfants. Jusque-là, il n'y a pas encore de rupture sur le terrain. Mais nous pensons que si ça ne se renforce pas, les médicaments pédiatriques peuvent tomber en rupture lorsqu'on va élargir l'approvisionnement au niveau du pays. Mais ce que nous avons fait, c'est que c'est vrai, nous sommes dans la transition vers TLD, et nous avons mis en contribution les différentes boîtes qui existaient au pays pour TLE. Donc, nous pensons que nous ne serons pas attrapés par la rupture d'ici là. Merci.
Peter, there is one more question in French.
All right, thank you very much, Dr. Richard. So next week, our topic is going to be on supply chain and COVID-19, and we are going to have the opportunity to discuss this topic further. I would like to remind all of us that if previous slides and recordings can be found on the Sequin website, and so please feel free to check out for previous presentations. And then also other related guidelines, protocols, articles can be found on the differentiatedservicedelivery.org website. I would like to then take this opportunity to thank all of you for joining us today, especially our panelists for sharing those great presentations. We really appreciate it. This is what makes Sequin what it is, our ability to share experiences, best practices, and innovations. We hope you'll be able to join us next week. Thank you very much and have a good day.
Merci.